Well, good afternoon, everybody. It is indeed my pleasure to be able to present the results of our recent multi-center trial that we did evaluating optical genome mapping in patients with acute myeloid leukemia. I want to thank the Bionano folks for the opportunity to present this exciting data. And I usually start off introducing the topic and showing some really nice animations. But after 2 days of having this webinar series, I'm sure you are very well versed in optical mapping. So I'm going to jump right into the whole study and the results that we found. Okay, so if we really look back at karyotyping and its association with cancer cytogenetics, it's important to realize that we've known about this association for well over 100 years, going back to Boveri, who first observed abnormal chromosomes in solid tumors. Over the course of the last 100 or so years, cancer cytogenetics has indeed become an integral part of the workup of patients with cancer. And we do know that we need to target both structural abnormalities as well as copy number abnormalities. We've been doing that by routine karyotyping, and more recently, well, I guess since the late 1980s, using multiple rounds of FISH with different types of FISH probes. And more recently, with the introduction of chromosomal microarray, we've been able to assess the whole genome and look at far smaller aberrations, submicroscopic aberrations, which go well beyond the visual aspect of karyotyping, but cannot detect balanced structural rearrangements or even map the chromosomal changes that we see and tell us exactly where they are coming from. And so a single technology that covers both structural abnormalities and copy number changes is highly desirable. And when I first learned about optical mapping, I guess myself and anyone else that looked at the technologies immediately thought, well, this potentially could be a great fit to achieve this goal. And I got a long way to achieving this goal with the creation of what I call the Cancer Genomics Research Network. And this was established for rapid assessment of emerging technologies. There are clear benefits of a research network. It enables us to really get hold of rare samples. If we think about these rare samples at an individual institution, the likelihood of getting them in a timely manner for a study is very small. But as we leverage our network, we can get access to these rare samples in a very expeditious manner. And it enables us, in addition to leverage a diversity of samples across multiple sites, many additional advantages like spreading the costs. And so there are many potential uses for this, including rapid assay validation and then assessment of clinical utility, which those of us working at large academic medical centers will need to enlist the collaboration of our local clinicians. And just to let you know, in the United States, that for the current first example of this type of network, these are my colleagues who were just fantastic in this collaboration. And here you see that's Alan Lennon, Jim Broach, Linda Bourne, Min Fang, Rashmi, Kanagal Shamana, Ravi Kola, and Yasmin Akari. The culmination of the multi-center study did come with our pre-publication in medRxiv, which you can see the listing over here for those of you interested in actually delving a lot deeper into the full results. I'm going to concentrate today really on some of the highlights of this study. The aims of the study were relatively simple. We wanted to look and establish the clinical diagnostic capabilities of optical mapping in cancer patients with AML. We did a blinded assessment and comparison of the results generated by optical genome mapping to results generated from routine clinical testing that was achieved in a clear, laboratory setting using current gold standard cytogenomic techniques. We had 100 patients where we received either peripheral blood or bone marrow samples. And these were patients who were subsequently were initially diagnosed and subsequently treated using intensive chemotherapy. The clinical samples were initially received and processed at 8 separate CLIA/CAP certified labs. And those are my collaborators that I showed you on the previous slide. And actually, I was going to say almost all of them, but in fact, all of them, 100% of them had karyotype, which is the gold standard. You'll see that only about 19% of cases had FISH, and only a very small fraction of them had chromosomal microarray. And again, this is routine clinical testing ordered by our clinical heme-onc clinicians. 80% of the samples in the study were unselective consecutive samples. We really wanted to get an idea in a consecutive manner how optical mapping would perform. But then we did want to really test the system by enriching for a wide range of anomalies. And these anomalies were chosen by my colleagues at their individual places. And when the optical mapping was done, those results were in fact blinded. The study was carried out under IRB protocols that were approved at each institution. The primary hypothesis was that optical genome mapping will provide clinical diagnostic results in a single assay, concordant with those achieved using multiple gold standard technologies. The secondary hypothesis was that optical mapping will uncover novel cytogenomic aberrations that will provide further insight into the pathogenicity of certain cancers. And certainly this is future work that, the results of the study lays the groundwork for multiple future studies. We assessed the clinical utility of optical mapping in 2 primary ways. So one, and the most basic of ways, was literally just to see the concordance. What we saw by routine testing, do we see the exact same thing by optical mapping? And that include both structural variation as well as copy number changes. And all of these were diagnosed in our CLIA/CAP approved laboratories. And then the second aspect was to say, over and above picking up what we saw by routine testing, were the things that we could pick up using optical mapping that were not identified by routine testing. From many of the studies that have come out from Bionano, it is apparent that there would be many additional findings. And so knowing that in advance, what we decided is that with all the additional findings that we would get across the 100 specimens, and indeed there were many, many additional findings, we wanted to focus specifically on ones that we could hang our hat on as potentially being clinically relevant. And the way we did that was by filtering all the additional optical genome findings with AML-specific genes. So we made comprehensive gene lists that we had across the 8 different clinical institutions, as well as the common AML-specific probe regions. And so we used these as a filtering, filter to further bring out specific optical mapping findings that crossed over with these regions. So we further assessed them using the following criteria. We looked at its presence or absence in the Bionano database. So that was a very large help because we wanted to rule out just common variants. And then we also only included sizes that were greater than 5 kb for insertions or deletions, as well as greater than 5 megabases for CNVs. And remember, these criteria were what we further added for the additional findings that optical genome mapping did over and above the routine methods. We decided that once we got the final filtering with those criteria, we would use an expert curation panel, and we dug deep into, we didn't have to dig deep. We actually utilized the expertise of our colleagues that were on the study, who got together to discuss the clinical significance of additional structural variants that were identified by optical mapping after we used all those filters. And then the final list of additional structural variants and copy number changes was compiled based on 2 tiers of clinical significance. So identification of 1 or more aberrations which are used in the ELN 2017 risk stratification system, or those that change the ELN risk status. And secondly, identification of abnormalities that may or may not be specified in the ELN 2017 risk stratification system, but for which sufficient published data demonstrates clinical significance. It was very important that we confirm any clinically significant findings, and we certainly went about and did that, and we confirmed every single one of them either by microarray or a PCR or Sanger approach. And let's get into the results. We stratified the cytogenomic results that were reported into 5 categories. So negative karyotype, either aneuploidy or partial aneuploidy, rearrangements such as translocations and or inversions with aneuploidy, rearrangements without aneuploidy, and then complex abnormalities with greater than 3 abnormalities. And this is a complicated table, but I want you to focus just on the green line. So the green line says that for each of those categories, we saw 100% concordance as defined by the criteria in the study. The arrows and asterisks I'm going to explain in a lot more detail, but essentially that points to additional findings that we saw. So here we see those 5 categories again, color-coded, and you can see the individual numbers of each one of those in this pie chart. The important thing is that we saw an additional 11 cases, and since we had 100 samples, this works out very nicely to 11% of cases where we saw additional clinically relevant findings that had been missed by routine methods. So specifically, 2 of the 9 cases that were reported with complex abnormalities showed additional findings. 2 of the rearrangements cases had additional findings. 4 of the aneuploidy or partial aneuploidy cases had findings. And even more exciting, 3 of the cases that were originally diagnosed with normal karyotypes actually turned out to have cryptic translocations. One of these involved a MECOM ETV6 rearrangement, and in 2 other cases, we saw a 511 translocation with the NSD 1 NUP98 translocation partnership. Going above those 11 cases, we saw that optical genome mapping refined the underlying genomic structure reported by traditional cytogenomics in another 13% of cases. We can also take this data and focus on the additional utility with respects to normal karyotypes, and those are the ones that I already spoke about. But if you break it down as a percentage of the normal karyotypes, there were 48 of them. So 3 of them were reclassified with these cryptic rearrangements. As I said, those were the NUP98 and the one with the MECOM rearrangement, but that actually works out to about 6.25% of normal cases, and that's really, really impactful. On the other side, if we focus strictly on the cytogenetically abnormal karyotypes, in 40% of cases, optical mapping better characterized the genomic aberrations by refining the structural breakpoints and identifying unknown cytogenetic elements like marker chromosomes or derivative chromosomes. And I'll show you some nice examples of that. Now, not all of those are obviously clinically relevant, or at least using criteria that we know right now. And so we focus really on those that are deemed to be clinically relevant. We see that 8 of 52 cases, or 15.4% of cytogenetically abnormal cases, yielded clinically significant findings. Okay, so if we think about this again in 3 different categories, just simply identifying clinically relevant changes not apparent by routine cytogenomic testing, there were 7 cases, 7 out of 100. Then you had additional findings as well as the potential to refine cytogenomic breakpoints and resolving unknown cytogenetic elements, meaning that traditional cytogenetics showed you something, but we have the ability to further refine them and find additional clinically relevant information. And that was in 4 out of the 100 cases. So there's the 11% total that I showed you in the previous graph. In addition, as I said, there were 13 cases that simply refined the cytogenetic breakpoints and resolved unknown cytogenetic elements. And I'll show you that. So starting off with that first category, identifying clinically relevant structural variation or structural rearrangements and CNVs not apparent. Here we see the 7 findings. There we see 2 of them being the NSD NUP98 rearrangements. And importantly, and this highlights the subjective nature of chromosome testing, especially when we deal with bone marrow preparations that don't give us the types of resolution that we're comfortable with, in our pediatric cases, really around 350 to 400 band level. Here you see that one case involving an inversion 16 was missed with the classic, MYH11 CB FB translocation. This is a case that I'm going to really end off with much later on, showing you a cryptic rearrangement as well, involving a loss of chromosome 5q. Here we see additional information over and above the ability to refine cytogenetic breakpoints and resolve unknown cytogenetic elements. And this was the one case that I showed you. It did have a normal karyotype, but as part of the normal workup, FISH was done, did identify a MECOM rearrangement, but in this case, it did not give you the translocation partner being ETV6. And then finally, here we just saw cases where we resolved unknown elements, and I'll show you, as in marker chromosomes or derivative chromosomes, and those are the cases highlighted in bold. It may be a little bit to see in the table, but the important aspect of this is, at minimum, this may just serve as additional markers when we are tracking minimal residual disease. My suspicion is that we will start to see added clinical significance of those. This is a new technology, so these types of things haven't yet been prospectively followed, and that's a lot of what we will be doing futuristically. So to show you some actual cases, this is one where there were no apparent rearrangements in the circus plot. There are smaller intrachromosomal events, as you can see from the color-coded dots, but they were further reviewed for significance by overlapping with many of the variants that we are familiar with that are polymorphic and benign in constitutional cases. But after doing that, you do see a deletion in this specific region. So here you can see the patient's DNA fragment in blue, mapping to chromosome 4, showing a deletion of TET2, a very nice example. The classic inversion 16, I cannot help just to show how beautiful this looks. There you see the circus plot starting from P to Q, that's the centromere in red, and then continuing from Q all the way back to P. And there you see on the circus plot a rearrangement between the short arm and the long arm. You can see that there's the patient in blue tracking to the reference as shown with the red arrows stopping at 16p13.11, dissecting MYH11, and then same patient fragment continuing at a different region of chromosome 16 at 16q22.1, dissecting through CBFB. And there you see the confirmation or the same results seen by FISH with the fusion very nicely. We did see additional findings by optical mapping. And again, this is the significance that will be determined, in prospective cases, as well as a very nice large deletion. So if we take the original cytogenetic result as shown over here, as ascertained by karyotyping and FISH, and we add on the optical mapping, here you can see that there is a change in refinement where we did see, an additional resolving of a translocation with better information as well as a deletion. This case really shows the beauty of resolving the clinical karyotype with optical mapping data. And what I'll do is show you the cytogenetics, which is over here. Let's break this up just for ease and clarity. and show you what the overall result looked like. So it's quite complex, as you can see, with multiple rearrangements and gains and losses all over the circus plot. But let's start off with the low-hanging fruit. And there you see a gain of chromosome 8. So you see a gain of chromosome 8 in the karyotype, and that's clearly seen even on the circus plot at a very high view, with a gain in the copy number algorithm clearly illustrated over there. The deletion 5, again, if we look at even at the algorithm, the copy number algorithm, it shows you a loss of 5q. So very easily seen there. And the nice thing about the BioNano, they've now worked on a very nice copy number algorithm, very similar to that of microarrays, where you can see the 5q loss over here and the whole gain of chromosome 8. So that leaves us with the additional material on 17, the loss of 20, and the additional material of 22. And you can straight away look at chromosome 20 and say, well, there's a loss of 20, but it's not illustrated on the optical map, the CNV like data over here. That looks normal. And even if you look at chromosome 20 over here, there's some small little gains and losses, but it certainly does not reflect a loss of the entire chromosome. So how do we resolve these? And what is the additional material on 17 and on chromosome 22? So let's focus on those 3 chromosomes. And let's start off with the add 22 at Q13. So at Q13, right at the distal end, we can in fact see there's a small little deletion, as well as a rearrangement between 20 and 22, which means that this whole region of 20 is now sitting at the end of 22. So that's our first resolution that says, yes, in fact, the add 22, the additional material is in fact this whole region of 20. So it is now a derivative 20 with a rearrangement between 20 and 22. We do see a loss on chromosome 20, which translates to this region. But again, this would not explain the whole minus 20. So let's get back to that in a second. Okay, moving on to the add 17. We see that there is a deletion of 17p. We now see there is also a rearrangement between 17p all the way to 20 at p11.21, involving this whole region. So that region now is sitting on chromosome 17, and this is further seen or ratified at the molecule level, where the patient's DNA maps for the first region to 17p, stops at p13.1, and then continues on chromosome 20. So you see direct evidence of that rearrangement at the molecule level. Again, that gives us a great explanation for the add 17. So the additional material from 17 is in fact this whole region of chromosome 20. So what about the rest of 17? We do see it's a lot more complicated. Here we see a deleted region over there, as well as a small gain, as well as a deletion. But what about the loss on 20? So if we break down 20, we've already given an explanation. This part of 20 is sitting on 22. So it's been repackaged away as an individual chromosome, as has this region, to 17. And this middle region is in fact lost. So that leaves that. So what has happened to that region? And if we fill in the full rearrangement, you actually see that those regions have in fact been repackaged on into chromosome 17. So that really gives a great explanation that chromosome 20 isn't really lost. It's primarily being repackaged, and it explains the additional material on 17 as well as chromosome 22. So to end, I just want to show the benefits and that of optical mapping, in that sometimes you may actually have very large rearrangements that are in fact cryptic, and that kind of sounds like an oxymoron. If you have a very large rearrangement, how could it be cryptic? In other words, subtle. And this came from this case where a very large derivative 5 resulting from a rearrangement between chromosome 4 and 5 was not apparent by cytogenetics. And the reason that this is important is because it in fact would result in a loss of 5q, which we know does have clinical significance. So here you see the original karyotype, where the only thing that was diagnosed, which was important, was the 8-to-21 translocation. But when you look at chromosomes 4 and 5, they in fact look relatively normal. And I think you'd be very hard pressed for anyone to say that this looks like there is a derivative chromosome. There are two possibilities. One is that this in fact is normal and that the rearrangement we saw is a subclone. We haven't been able to yet go back to the original metaphases and by FISH look to see if they're two subclones or not. But again, it highlights the issue. And what you will see is that there is a rearrangement between chromosomes 4 and 5 as detected by optical mapping. And what you'll see, this was confirmed by by microarray. Here you actually see that there is a loss of this whole region on chromosome 5, and that's replaced by this whole region on chromosome 4. So you do have an effective loss of 5q, which would be clinically significant. But the reason it's cryptic is that most of us who look at chromosomes routinely know that chromosomes 4 and 5, the banding material is relatively similar, particularly when you have banding levels of 3 to 400. And in this case, you have a region of almost identical size replacing the normal region of chromosome 5, which is why we could regard this as being cryptic. So overall, we saw many cases where optical mapping resolved the karyotype, gave us additional information. And part of the exciting forward-looking studies that we will be doing is to try understand the significance of all these new findings. So as a general summary, optical mapping is a powerful new cytogenomics tool for assessing chromosome structure and copy number. And I think this is the second day of this conference, and I think that is already highly evident. We see, at least in the study, 100% concordance with traditional cytogenomic analysis for karyotype, FISH, microarray, as well as seeing additional clinically useful information that we cannot discern by using routine cytogenetic karyotyping or FISH. It has the ability to resolve complex rearrangements observed by G-banding. It can reveal, the partner translocations, which in cancer is very important for identifying those chromosome gene fusion partners. And these are some of the examples. And I highlighted the MECOM ETV61 in this presentation. And it certainly provides additional new information not revealed by standard cytogenomic workup. Specific to this study, we see that optical genome mapping is equivalent in its diagnostic scope compared to routine cytogenomic methods. It added significant new information in upwards of 11% of cases, with a potential increased diagnostic yield of 6.25% in cases reported with normal karyotypes. If we focus on abnormal karyotypes, in 15.4% of the cytogenetically abnormal karyotypes, it has the ability to reveal clinically significant new events. And as high as 40% of those cases show new findings. And again, that will be part of the future studies to see what they are. And as I said, at minimum, are these effective in helping us track minimal residual disease? So OGM provides a more comprehensive genomic analysis for patients with AML. It has the ability to replace 3 independent assays. You have the karyotype, FISH, CMA. We can detect all those abnormalities at once. This really represents a significant time and cost saving potential for clinical AML testing. It removes the subjective testing algorithm at individual sites. And this, I think all of us recognize, the way that cytogenetics is done differs literally from laboratory to laboratory, from institution to institution. In many cases, the lab helps to say what should be the next step. In some cases, it's the physician who orders a whole battery of FISH probes and then chooses new ones as new results come up. And so what this can do in one shot is standardize care and healthcare costs. And the most exciting thing that I see this is a potential to remove disparity in healthcare, because many of these decisions are actually based on what a patient can afford or not. In some cases, There are labs that do significantly extensive panels of FISH and karyotyping, potentially even CMA, and that will be covered. But for those patients who can't afford that whole extensive battery, we now have a potential one-step test that can do this all in once and really take away those disparities. So the next step certainly will be the discovery phase. What recurring abnormalities do we see? Can we track minimal or residual disease? What is the prognostic potential value of any new findings? Again, that could lead to potential therapeutic value. And this is all going to take a lot of fantastic collaboration with our clinicians. And so I'm going to end off there. I do want to recognize a fantastic group, as you see over here. I've mentioned the primary individuals at each of the centers at the very beginning, but there are more than just those individuals, as you can see from this slide. And my sincere thanks to each and every one of them. We literally met weekly to discuss the results and update. It's been a 2-year effort. And I do want to thank the Bionano folks for supporting us on the technical side. It's been a terrific adventure. And I'm going to stop there. Thank you very much.